So the gum pads are divided into 10 segments by each groove called as transverse grooves, and each of these segments consists one deciduous tooth sac or tooth bud, which give rise to 10 deciduous teeth in the upper and the lower. And the gingival groove, this is the gingival groove, and this separates the gum pad from the palate in the upper and the floor of the mouth in the lower, which the gingival groove. The gingival groove demarcates the gum pads from the palate in the upper and the floor of the mouth in the lower. Okay. Now this is the gingival groove here, and these are various, this is the dental groove and this is the lateral sulcus and various transverse grooves. Okay. And these are the 10 teeth buds in a radiograph. Okay. So the groove separating the gum pad from the palate is called gingival groove. The groove which separates the gum pad from the palate in the upper is called the gingival groove. Chronological age of the child is related to the developmental status or related closely to the dental status, dental age, or to the skeletal age, or independent. See, ages can be of different types. One is chronological age, biologic age, skeletal age, dental age, or mental age based on the IQ quotient. Okay. What this question states is chronological age of the child is it related to the skeletal or dental? See, it is often independent. It might not be related to either the skeletal or dental age, because many a times we see a patient tells that he or she is around 11 or 12 years, but still the premolars would not have come, isn't it? Or patient says he is 9 years or 10 years, but all permanent teeth would have erupted, including second molars also almost seen erupting. So often the chronological age is independent of either the skeletal or dental age. Now skeletal age gives you the maturational status. That also might not be related to the chronological age. So blindly do not follow the chronological age. So you have to assess the dental age of the patient separately and the skeletal age. So this states this chronological age is independent of skeletal and dental age. Though developmental age, that is the skeletal age, dental age and chronological age are related. See, in 30 to 40% of the cases all will sync, but in the other 50 or 60% of the cases they are different, or it might not match, okay, to each other. So their correlation is not good and each occurs independent of the other. Okay. However, chronological age is more related to the developmental age. Okay. And all of the following are useful in assessing the dental age from the radiographs. So these things can be assessed, except number of primary teeth remaining, that also you can know in a radiograph. Amount of root resorption of permanent teeth can be seen in a radiograph. Sequence of eruption of permanent teeth, can that be visualized in a radiograph? Sequence of eruption we can't visualize. Which tooth will erupt, what, when and how, we can't tell. Okay. The degree of crown development, yes, depending on the maturation. So you can see the degree of crown development, you can see the amount of root formation, you can see number of primary teeth remaining, that is which have not exfoliated. All these things you can see on a radiograph, but you just cannot tell the sequence of eruption. Sequence of eruption cannot be told by a radiograph. Okay. A radiograph of a jaw of a newborn or normally indicates calcification of how many teeth. Say newborn or an infant or a neonate, what you see is 20 teeth, isn't it? In addition to the 20 primary teeth, you see the first permanent molars which are calcified at birth. So 20 plus 4 is 24 teeth. So in a radiograph of a newborn, you see 24 teeth. So radiograph at birth shows excuse me, calcification of all the primary teeth 20 and first permanent molars. So totally 24 teeth. And the sequence of eruption of primary teeth, the sequence is not ABCDE, isn't it? Because D erupts earlier to canine. So ultimately it is ABDCE. Okay. Now D, that is the first primary molar, erupts earlier when compared to your primary canine. and after that your second primary molar. It is same in both the upper and lower arches. ABDCE. Okay, the similar pattern ABDCE. And the time taken for the deciduous dentition to reach occlusion after erupting in the oral cavity, like how much time does it take to reach the occlusal level? It is 2 to 12 months, isn't it? By 30 months all the teeth are erupted. So, by how much time it will take to reach the occlusal level is in 2 to 12 months. So, a primary second molar becomes ankylosed most commonly because, now why a primary second molar becomes ankylosed? That is, even it is over retained. Now, why this happens? Is it in the root formation, or during physiological root resorption, or due to the failure of alveolar bone of the tooth to grow, or all of the above? It is basically due to the physiological root resorption. What happens is, one root is resorbed, the other root is not resorbed. It has got both the mesial and the distal roots. If the two roots, one root is resorbed and the other root is not resorbed, obviously the tooth is ankylosed, or it will stay or over retained in the oral cavity for a longer duration when compared to the norm. At what age the child is expected to have 12 primary and 12 erupted permanent teeth? Like, there should be 12 primary teeth and 12 permanent teeth. Now, 12 permanent teeth, how you have to calculate? First molars are there at 6 years itself, so 4 teeth are done. Then again 4 incisors on the top, 4 incisors on the bottom. So, 4 plus 4, 8 plus 4, 12. So, that means to say your incisors should be erupted and your molars should be erupted. Molars, first permanent molars are by the age of 6 years. Now, both the incisors have to erupt, then the upper lateral incisor erupts by around 9 years, 8 to 9 years. Okay. Lower incisors would have erupted by then, by 8 years. So, 8 to 9 years, so approximately it is 8.5 years. Clear? So, you will have 12 primary teeth, that is C, D and E. So, 3 in each quadrant, 3 fours are 12. And 12 permanent teeth, that is your first permanent molar and all your incisors, permanent incisors. Okay. The same thing, 12 teeth. So, your upper lateral incisor erupts by around 8 to 9 years of age. So, approximately by 9 years you are going to have 12 primary and 12 permanent teeth, and after that at least an year or so you hardly see any exchange of teeth, because your premolars erupt only by the age of 10 plus. Okay. So, approximately 1.5 year you will have no teeth erupting. A radiograph of a 4-year-old child reveals no evidence of calcification of the mandibular second premolar. This indicates what? Is it too early to take a final prediction, or the teeth may develop later, primary second molars extracted to allow the mesial drifting, or the child may never develop second premolar? So, here the tempting is you can tell D or you can tell B, but the thing is a 4-year-old child, by now at least you should have seen calcification. Okay, because you see the third molar calcification at the age of 8 years. So, second premolar you should see at least by 2 to 4 years, but still you cannot comment, because many a times the second premolars are missing, many a times they are congenitally missing, or sometimes there is an over retained primary second molar, then also the stimulus will be less because of the formation. So, the better would be to say that the teeth might develop later, but when the same thing is asked at 6 years, definitely you can say the teeth will not erupt, or there is no teeth to erupt. Normal variation in the eruption of permanent teeth, like how much variation can occur in the eruption, that is there could be a variation of 2 to 4 years, like one side they would have erupted, the other side they would have not erupted. So, that variation in time could be approximately 2 to 4 years, and it is more important to watch bilateral development of dentition. What does this mean is, if one side, that is right or left side, you see the tooth erupting, then the other side it is not erupt, you can approximately wait for at least 2 years to take a decision. Usually the teeth erupt 5 to 6 months earlier in girls compared to boys. When you see the sexual dimorphism, they erupt relatively earlier in girls when compared to boys. So, the variation in the eruption time is approximately 2 to 4 years. And the sequence of eruption in the permanent maxillary dentition is 6, 1, 2. Instead of the canine, it is the first premolar which erupts earlier, followed by 5 and 7. Sometimes it is 6, 1, 2, 4, 5, 3, 7. After both the premolars, the canine erupts. But majority of times it is first premolar followed by canine and then the second premolar. Okay. So, the most common sequence is 6, 1, 2, 4, 3, 5, 7, and in the mandibular arch it is normal 6, 1, 2, 3, 4, 5, 7, and frequently you see 6, 4, 5, 3, 7, both the premolars followed by the canine. Okay, that is the other option, but most common is 6, 1, 2, 4, 3, 5, 7, that is the first premolar ahead of the canine. Tooth shows beginning of eruptive movements in which stage of Nolla's classification? Like Nolla has given 10 stages of tooth calcification. Like the 6th stage, the crown is completed. 7th stage, 1/3 of the root, 2/3 almost root and the apical end, that is the last. So, the moment the crown is completed, you can see some amount of eruptive movement which is generated. But a tooth to erupt in the oral cavity, you need at least 2/3 of the root to totally form, minimum. At least 50 to 60% of the root has to be formed for a tooth to erupt in the oral cavity. Clear? So, if you allow the tooth to form by 2/3, then it will erupt into the oral cavity. But the initial eruptive movements are seen the moment the crown is completed. Okay, so that is stage 6. You need not wait till stage 8. Now, stage 8 is when 2/3 of the root completion is formed. That is when the tooth clinically erupts in the oral cavity and the tooth forms, and tooth erupts in the oral cavity and it comes. Okay, so now this is in stage 8, but the initial eruptive movements you see in stage 6. Okay. So, Nolla has given 10 stages of development of teeth. By stage 6, the crown formation is completed. So, at this stage you see the eruptive tooth movements. Okay. So, by the 8th stage, 2/3 of the root is formed, which will allow the tooth to pierce the oral cavity and erupt. So, clinically you can see the tooth eruption once the 2/3 of the root is formed. That coincides with the 8th stage, whereas eruptive movements begin with the 6th stage. Okay? And eruption of the teeth is delayed in all of the following, except in all these conditions eruption is delayed: hypothyroidism, cleidocranial dysplasia, rickets, cherubism, cretinism, and also dentigerous. Whereas in acromegaly and hyperthyroidism it is hastened. The process of eruption is hastened. So, in acromegaly and hypothyroidism, eruption process is hastened. A 15-year-old patient, a 5-year-old patient suffering from ectodermal dysplasia has no primary or permanent teeth. Normally, in ectodermal dysplasia, you see all the structures from the ectodermal layer being affected. Like you hardly see any teeth. Maximum it will be complete anodontia or oligodontia. Few teeth might be present. Now, in this condition, there are no primary or permanent teeth. Now, when should you construct the dentures? In these cases, only after skeletal growth is completed, immediately and worn regularly as there is no effect on the basal bone, or immediately but worn only for eating, or dentures are contraindicated. The reason is, if you see the teeth erupting, you see the formation of alveolar bone. As you know, for the functional matrix theory, when a tooth is present, the function of the tooth is elicited in the formation of alveolar bone. So, the response is the moment the tooth erupts, there will be formation of your alveolar bone. Since the teeth are not there, there is no formation of alveolar bone. The reason why you don't place implants in a young patient is you allow the alveolar bone to form totally. You want the vertical bone growth to cease, isn't it? So you don't place implant below the age of 15 or 16. Even your crown also you will not place. If you want to place your PFM crown or a metal ceramic crown, you will place only after the age of 16 plus or 15 plus. Reason being, you allow the tooth to erupt fully to the occlusal level. Now that will take at least 2 to 3 years post eruption. So your second molars will erupt till the age of 12 years. So post eruption is approximately 15 to 16 years. So you don't place either your PFM crown or an implant or anything, because the alveolar bone is correspondingly developing. So whenever there is no tooth, what you see there? There is hardly any alveolar bone, because there is no function, no bone formation. So the non-skeletal tissue, that is your tooth, you will not allow the formation of the skeletal tissue or osseous tissue, your alveolar bone. So here there is hardly any alveolar bone. So you can make the dentures immediately and they can be worn regularly, as there is hardly any effect on the bone. The common anomalies related to the tooth number. Any anomalies in relation to the tooth number, there are like how many anomalies are in the descending order. One is your missing permanent teeth, okay, like your third molars, and then extra permanent teeth, extra primary and missing primary. Like which is common? Which is the most common is missing permanent teeth. Among missing permanent teeth, the most common is your third molars, isn't it? So missing permanent teeth is the most commonest thing you see in the number, anomalies of tooth number. Missing permanent teeth is the most common, followed by extra permanent teeth. That is, extra permanent teeth could be your supernumerary teeth or supplemental teeth. Either your supernumerary teeth or supplemental teeth. In that you have mesiodens, which is most common, followed by supplemental teeth you have lateral incisors, okay, and then extra primary and missing primary. In extra primary, first will be an extra tooth, and then the missing primary is very rare to see, okay. So you have two components, one is missing permanent teeth followed by extra permanent, then extra primary, then missing primary. Missing primary is the least, that is infrequently you see, hardly you see missing primary teeth, okay. So the most common missing permanent teeth are third molars followed by lower second molars, then your upper lateral incisors. As I told you earlier, there is something called Butler's morphogenetic theory, where the dentition is divided into various segments: incisors, canines, premolar and molar. The distal most tooth is most missing, okay, in each segment. So first is your third molars followed by lower second molars, then your upper lateral incisors, the missing frequency. Then the most common extra permanent teeth are your mesiodens, then your paramolar or fourth molar, and then your supernumerary premolars. These are the extra permanent teeth. The most common is mesiodens, and most common extra primary teeth are upper lateral incisors. Upper lateral incisors you can see as supplemental teeth, extra primary teeth, followed by lower and upper cuspids, and it is very rare to see a primary teeth missing, congenital. And most frequently missing primary teeth are upper lateral incisors. And a peg-shaped mesiodens is also called as Zepfenstein, that is the mesiodens, which is a peg-shaped is referred to as that. Okay. And mesiodens is present in between the two upper central incisors palatally. Okay. Both conditions of supernumerary teeth and partial anodontia are found in which condition? Both, like supernumerary is extra teeth, now anodontia is absence of teeth. So you are in the number, you are seeing both contrasting features. One is more number of teeth, the other is less number of teeth. Now it is commonly seen in cleft palate, where if the cleft is running through the alveolus, okay, that portion of the teeth are missing, okay. And many a times you see mesiodens or supernumerary teeth also, a lateral incisor to be found, and the missing teeth are lateral incisor, canine or premolar, because that is the region where the cleft normally runs. If a child is born and lived for the first 8 years in an area which contains water supply with 2.5 parts per million of fluoride, mottling develops. Now this is an indirect question where it says, like if a child is in a region of fluoride water till the age of 8 years, what all teeth are affected? So till 8 years, which all teeth are calcified? So you have to think retrospectively. Till 8 years of age, which all teeth are calcified? So by 8 years, most of the teeth are calcified, isn't it? Calcification begins for all the teeth. Your first permanent molar will start at birth, and last tooth which is left is your third molar. The third molar is at the age of 7 or 8 years, isn't it? Or after 8 years. So other than third molars, all the permanent teeth are affected, isn't it? So if a child is lived for first 8 years in a fluoride area, then all the permanent teeth are affected except for the third molars. A child at 7.5 years of age receives extended course of tetracycline. Clinical crowns of which of the following teeth are likely to show discoloration? Again, this is a question where you have to think about the eruption of the teeth, the sequence. Now, by 7.5 years, he receives a tetracycline dose at 7.5. So, by then, most of the permanent teeth are erupted. So, the calcification of most of the permanent teeth is done. Okay. So, only one tooth which is left is your molars, that is third molars. Other than third molars, all the teeth, the calcification is almost done. So, hardly you will see any objection or any aesthetically pleasing, anesthetically teeth in the oral cavity, because all the permanent teeth will be discolored? Absolutely not, because by then calcification is done. Next, only incisors or first molars are affected? Not the case. Only premolars? Not the case. Only teeth which would be affected here would be at the most is your third molars or to a part second molars. Other than that, no other teeth will be affected. By 7 or 8 years of age, crown formation of all the teeth except the third molars is completed. So 7.5 when he takes, so hardly there will be any effect. Placing the beaks, that is the extraction forceps, into the furcation of primary second molar during extraction in a 6-year-old child is contraindicated because why you should not place the forceps deep? What will happen? It will affect the successor tooth, the succedaneous tooth bud. So proximity of the succedaneous tooth bud, because when you are extracting a primary second molar, the tooth which is succedaneous there is your second premolar. So there is every possibility of you hurting or damaging the second premolar tooth bud. That is the reason you are to avoid placing the beaks into the furcation. The role of pulp in resorption of primary teeth. What is the role of pulp? When the tooth is resorbing, whether it is a passive, active or resists or activates, it is basically a passive participant. Okay. Good contacts in primary teeth with lack of spacing. In primary teeth, if you see, or in the primary dentition, there are good contacts, proximal contacts with no spacing. What does that indicate? Definitely this candidate, either he or she, will be a candidate for crowding in the permanent dentition. If there is spacing in the primary dentition, which are referred to as physiological spacing or anthropoid spacing, it is absolutely normal, because the mesiodistal width of the primary teeth is less when compared to that of the permanent teeth. Okay. So if the contacts are tight and there is lack of space in the primary dentition, 100% there will be crowding in the permanent dentition. Okay. So spacing in primary dentition is acceptable and it is physiologic spacing. What they say is, if there is based on the lower anterior spacing in the permanent dentition, if already there is crowding, 100% there will be crowding in the permanent dentition. If there is no crowding and tight contact, then 70% of the cases there will be crowding. Okay. Spacing less than 3 millimeters, 50% chances. If spacing is more than 6 millimeters, then you will see no crowding in the permanent dentition. That is, if your physiological spaces are around 6 millimeters are present in the primary dentition, then you will hardly see crowding in the permanent dentition. Am I clear? So, whenever anybody asks there is spacing in the primary teeth, okay, you should not be worried or concerned. So, definitely you can say this fellow will not have any crowding in the permanent dentition. Okay. And primate spaces, what contributes to these spaces are two things. One is primate spaces, the other one is leeway space, which I will explain to you, the physiological. One most important thing in deciduous dentition is primate spaces. Why they are called primate spaces? Because they are seen in most of the primates. Now, primate spaces in the deciduous dentition are absolutely a normal finding. They are not abnormal. It is a usual finding, and these are present in between upper B and C and lower C and D. That is, in upper you see mesial to the canine, that is between B and C. Lower it will be distal to the canine, that is C and D. So, primate spacings in deciduous dentition are absolutely normal, and they are seen mesial to the upper canine and distal to the lower canine, that is upper between B and C and lower between C and D. Okay. So, primate spaces are also referred to as simian spaces, or after they are named after Baum, who had found it, as Baum spaces or anthropoid spaces. Primate spaces are also called as anthropoid spaces, Baum spaces or simian spaces. Primate and simian are same, anthropoid this thing, and they are seen between B and C and D. Okay. And this primate spaces are responsible for the early mesial shift. Now, as I told you earlier, the distal aspect of the primary second molar represents the flush terminal plane. Okay. Now, if the first permanent molars erupt, they will also be in an end-on relationship if the primary second molar dentition is in an end-on relationship. So, how do we get a class 1 molar relationship? So, the lower molar has to shift mesial, isn't it? When the lower molar shifts slightly mesial, then only you get a class 1 molar relationship. Now, how will the lower molar move mesially? So, there are two natural phenomena which could occur. One is early mesial shift, the other is late mesial shift. Now, early mesial shift is because of the primate spaces. The primate spaces contribute to the early mesial shift, which are present between upper B and C and lower C and D. Now, late mesial shift is because of the leeway space of Nance. Leeway space of Nance is around 1.8 millimeters in the upper arch and 3.4 in the lower. So, lower it is more. So, the lower dentition shifts more mesial. So, you get a class 1 molar relationship from the end on or flush terminal what you see. So, the mesial migration or a class 1 molar relationship is accomplished by either early mesial shift or late mesial shift. Now, early mesial shift is because of your primate spaces or simian spaces or anthropoid spaces or Baum spaces, which are seen in the upper between B and C and lower C and D. And late mesial shift is because of the leeway space of Nance, which is 1.8 millimeters in the upper and 3.4 in the lower. Clear? So, Baum spaces are seen between the upper lateral and canine, lower canine and molar. This physiological spacing is common spacing between all the primary teeth, and it is absolutely normal. The average leeway space available in each half of the maxilla, each half. So, you have to be very clear and specific. In maxilla, as I told earlier, it is less, first thing, and mandible it is more. So, less is maxilla is 1.8 total arch. So, 1/2 is 0.9. Okay. Whereas in mandible it is 3.4 millimeters totally. So, 1/2 is 1.7 in mandible. Okay. It is more in the mandible, that is why it will allow the lower molar to shift furthermore mesial. So that is the reason it is more important for us to maintain the space if any primary tooth has lost early. If any primary tooth is exfoliated early, we have to maintain that space. Otherwise, we will lose the leeway space. The moment your first primary molar is lost, your second primary molar is slightly mesially migrate, then your first molar also will migrate. So it is essential for you to maintain the space. That's why you use space maintainers till the permanent tooth, corresponding succedaneous tooth erupts. So the space is approximately 1.8 mm in the upper and 3.4 in the lower. This accounts for the late mesial shift, which will help to establish a class 1 molar relationship from the end on molar. Most of the leeway space is contributed by which tooth? As I said, what is leeway space? Leeway space of Nance is the difference of the mesiodistal width between the canine and the primary molars, between the primary canine and the primary molars to the permanent canine and premolars. Okay, and we know that the premolars are less in mesiodistal width when compared to the corresponding primary molars. Okay, so which among the teeth, that is either your primary C, D or E, which is contributing more to the leeway space? It is E. That is the reason leeway space is also called as E space. Okay, so the mesiodistal width of the second primary molar is one which contributes to the leeway space. The mesiodistal width of the second primary molar is more when compared to the corresponding succedaneous second premolar. Okay, so that contributes more to the leeway space. So the same thing, leeway space in the lower is around 3.4 millimeters, the entire arch, and most of it is contributed 70% by your primary second molar. So it is also called as E space or leeway space of Nance. Difference in the width of permanent and primary incisors is called as incisal liability. Which is more, primary incisors or permanent incisors? Permanent incisors. So that difference is called as incisal. Normally it is around 5 to 7 millimeters, 5 to 7 or approximately 7 to 8 in the upper, 5 to 7 in the lower normally. This is called as incisal liability given by Wayne. Now the reason is the permanent incisors are usually larger mesiodistally and you need some amount of space to accommodate the permanent incisors. So this is called incisal liability, and how to accommodate this space? The difference is approximately 7 to 8 in the upper and 5 to 7 in the lower. This is called incisal liability. How do you overcome? Now where do I get this distance from? Now if I have 5 to 7 millimeters, how do I get that space? Now how do I get that space is by utilizing the physiological spaces in the primary dentition, which I have told you earlier. The physiological spaces in the primary dentition, which are the normal spaces which is seen, that is one, and the other is using the increase in the intercanine width. The intercanine width establishes with the eruption of your permanent canines and then the inclination of the permanent incisors. See, your lower incisors are always upright to the basal bone, they are upright lower incisors, whereas your permanent incisors are at an angulation, or to tell they are at an inclination, labiolingually inclined. So that is why the inclination of your permanent incisors, the intercanine width and physiological spaces, these three contribute to your incisal liability. So how you overcome incisal liability is by the inclination of your permanent incisors, by utilizing the physiological spaces and the intercanine dimension. Now intercanine width is established with the eruption of canines. So till then you have the intercanine width. At what age the maxillary intercanine dimension is essentially complete in boys and girls? Like what age is the intercanine width established? In boys it is slightly higher, it is around 18 years, actually it is 15 to 18 years, and in girls it is around 10 to 12 years. The reason being they mature earlier when compared to boys. So there is a sexual dimorphism where the intercanine dimension of the upper arch is established by 15 to 18 years in boys and 10 to 12 years in girls. So obvious choice would be C, where 18 years in boys and 12 years in girls. Then the intercanine width increase in maxilla in girls is usually completed by what age it is completed? It is completed by 10 to 12 years. The girls, that is your transverse dimension. The first the growth to cease is in the transverse dimension. The growth will cease first in the face, the growth will cease first in the transverse dimension, that is the width, the transverse dimension. Then it is followed by the sagittal dimension, that is your anterior posterior, that is the depth, and then the last is your height, that is the vertical dimension. The growth in relation to face, not cranium. I am speaking in relation to the face. Cranium is again different. I will deal in growth and development. So the growth first ceases in the transverse plane, that is the width. That's why the intercanine dimension